Trauma radiology utilizes advanced imaging techniques to quickly and accurately diagnose injuries, especially in emergency situations. The speed of diagnosis in trauma radiology is crucial, as timely imaging can significantly improve patients' outcomes. Common traumatic injuries include fractures, internal bleeding, and soft tissue injuries. Understanding these injuries helps radiographers tailor their imaging approach to provide the most relevant information as quickly as possible with the least amount of trauma to the patient. This is an illustration of the ideal trauma team structure with team member positions in relationship to the patient. What is the role of the radiographer? The radiographer performs as part of the ER healthcare team, and they must possess the skills to think critically and produce images that are diagnostic and timely. Remember, these are trauma images and not routine diagnostic x-rays. The radiographer must also practice ethical radiation protection, provide competent patient care, and perform quality diagnostic imaging as ordered. Trauma imaging differs from routine diagnostic imaging. The radiographer must understand normal anatomy and pathology and what is normal and what appears to be abnormal in the image. Proper technique and positioning for chest x-rays are essential for accurate results. Typically, patients are positioned upright if possible to allow for better visualization of air and fluid levels. Effective positioning and technique lead to clear X-ray images, aiding in accurate medical diagnostic assessments. Trauma exams are not routine diagnostic exams. They are solutions to analyzing specific problems caused by trauma to the patient. The radiographer must understand that the physician is in charge, but the radiographer must also evaluate the situation. The chest examination is usually the first exam requested. The AP pelvis exam is crucial to determine that major vascular structures are not compromised and the patient is subject to bleeding out. The cervical spine is often requested first by inexperienced ER personnel, but as long as the spine is stable and immobile, the chest and pelvis should be taken first. The lateral C-spine image demonstrates trauma based upon the force that was involved with the trauma. A lateral cervical spine X-ray may indicate not only bony trauma, but also trauma to the intervertebral disc. Decreased intervertebral disc space may indicate a herniated disc. An adequate cervical spine series includes 3 views: a true lateral view, which must include all 7 cervical vertebrae, as well as the C7-T1 junction; an anterior-posterior view, AP, and an open mouth odontoid view to visualize the dens. Here we see a lateral C-spine. To the right, we have labeled the lateral C-spine to indicate which discs you're looking at, which include C1 through C7. Also notice that C7-T1 joint space is shown, and the C1-C2 joint space and allantoaxial joint space is shown. Notice the lack of height that shows a fracture and the loss of alignment in the curvature of the spine. In analyzing the lateral cervical spine, we look at the different curves, the spinal laminar line, the posterior line, and the anterior line. We want to take a look at these to make sure that they are smooth and not disrupted. Let's take a look at the lateral C-spine, and we want to look at the relationship of the bone, the soft tissue, and the air in the trachea. As we go to the area of C2, we should see a retropharyngeal space of about 7 millimeters. In other words, the soft tissue between the trachea and the bone should be approximately 7 millimeters. As we progress down the spine itself, we'll notice that the air at C4 and above up to C2 is about 50% of the size of the vertebral disc itself. Below that, it should widen out to be approximately the same size, or 100% the same as the vertebral body, and this is below C4. If we take a look at the retrotracheal space at about C6, we're looking at 22 millimeters, whereas in children, because children obviously are a different size, it would be 14 millimeters. So again, let's take a look at the abnormalities in the curves. Remember, the focal contour, or the abnormality of the focal contour, is important. At C2, it should be less than 7 millimeters. At C3 and C4, less than 5 millimeters. And at C6, 22 millimeters in adults and 14 millimeters in children. Abnormal measurements may indicate soft tissue swelling from obvious or occult fractures, hematomas, or abscesses. Let's take a look at the anterior allanto-dens interval. This is the space in front of the dens where the dens projects up through C1. So the dens of C2 is projecting through C1, and there is a space where the dens fits in. This would be 3 millimeters in adults and 5 millimeters in children. If it's greater than 3.5 millimeters, we have an injury. If that injury is a greater than 5 millimeters, we have not only an injury, but we also have a rupture and instability. We also want to take a look at the atlanto-occipital difference. Increased distance may indicate an atlanto-occipital dislocation. In other words, the skull has separated from the cervical spine itself. The distance from the atlas, C1, to the occiput should always be less than 5 millimeters. The image on the right shows a normal interspace between C1 and C2 and the dens projecting through. To the left, you'll notice that we have a predental space that is greater than 3 millimeters. This indicates that we have a fracture. Here we can see the fracture of the dens itself. If you see a fractured dens, you want to definitely check for atlanto-occipital dissociation with this fracture of C1. Let's take a look at these two images. They're both showing that there is a facet damage, but one would be unilateral and one would be bilateral. How can we tell? It is by the amount of distance that the vertebra is forward above the vertebra below. Here we see the difference of the two. And obviously, the first is a unilateral facet dislocation, and the second is a bilateral dislocation. This image shows a compression fracture. The compression fracture is of C5. This image shows a burst fracture. The burst fracture and dislocation are located at the level of C6. By analyzing the AP view of the cervical spine, we can also gather a lot of information about fractures and dislocations. First, we must see the entire AP cervical spine without having the mandible superimposed over the vertebra. Now we're going to take a look at this AP view, and we want to look at symmetry and size and alignment of spinous processes. We're also looking at the edges of the vertebra itself. You want to have smooth rolling lateral edges. Notice here that we have the two vertebrae, but I don't see the spinous process there. Could there be a problem? There's a spinous process here. Let's take a look at this lateral view, and we see that there is an anterior dislocation on the lateral. Can we see it on the AP view? When we look at the AP view to begin with, we'll notice that all of a sudden we don't have the spinous processes projected over the vertebra. Remember, the spinous processes themselves project on the vertebra below the spinous process. So if you have C5, that spinous process is going to project onto C6. If we do not visualize the spinous process, we have an anterior dislocation, and that can be seen on an AP view as well as the lateral view. Remember, on the lateral view, we're looking for our lines, and we're also looking for the soft tissue, the air in the trachea, and the alignment of the vertebral bodies. If we have a difference in the vertebral body width, if it is 50% or less, it would be a unilateral dislocation. If it's 50% or greater, it's a bilateral dislocation. Remember before, we did not see the spinous process projected over the vertebra below on an area that had a dislocation. If one of the spinous processes is off to one side, you have a facet dislocation that could be present. Now let's analyze the open mouth odontoid view. The images to the right show the open mouth position and what the odontoid view should look like. To the left, we've magnified that view, and let's take a look at what we see. First of all, we'll see the body of C2, and notice the dens is projecting upward through the lateral masses of C1. Fractures of the dens or odontoid are not uncommon. Here we see an open mouth showing an odontoid fracture. Mouth odontoid view. First of all, let's take a look, and here is C2. Next, we're looking at the lateral masses, or the ring of C1 that surrounds C2. The area above is not a fracture, it is very simply the teeth and the difference between the two front teeth. Make sure that the two front teeth are not projected over the lateral masses of C1. The C1, C2 articulation. And you'll notice that we have a fracture of the dens, but it's only slight. But also take a look at the lateral masses, and the joint spaces between C1 and C2 have dramatically dropped because it's like having a ring around the dens, and then breaking that ring, the lateral masses will fall down and make that joint space smaller. Here we see an open mouth view. Now let's take a look at the relationship of the dens and the lateral masses. You see a difference there? There's the dens. There's the lateral masses. But you'll notice there's a fracture of the dens, and the lateral masses have compressed so that we don't have a large space between C1 and C2. This is called a Jefferson's burst fracture. This image shows exactly the ring of C1 that goes around the dens of C2. And notice the fracture of that ring, allowing the body of it to actually fall and close that joint space. Here we see an image where the right side of the chest is totally crushed. Lots of fractures, lots of trauma. We also have not only soft tissue damage, but we have ribs, and we also have some subcutaneous air. When you break ribs, you can get a flailed chest. And here's the mechanism of a flailed chest. Notice there's a difference when we take in an inspiration, the mediastinum shifts with each breath, and the loose part of the chest wall pushes in. On expiration, the loose part of the chest wall pushes out, and this is why it's called a flailed chest. Here we see a classic chest x-ray that shows a widened mediastinum that is representative of a ruptured aorta. And we see the patient, we also see a cine of the ruptured aorta, and the surgical process that is using to fix it. Chest x-rays are indicated in trauma cases where there is a suspicion of a pneumothorax, hemothorax, rib fractures, or pulmonary contusions. They help in the initial assessment of the patient's condition. With a pneumothorax, the chest x-rays are crucial for identifying and taking prompt intervention. For a hemothorax, again, excellent for diagnosing and evaluating the amount of fluid in the thoracic cavity. Rib fracture evaluation. Chest x-rays are used to assess rib fractures, which can complicate trauma cases and require management. And finally, pulmonary contusions. Assessing pulmonary contusions through x-ray is essential for understanding lung injuries post-trauma. Let's take a moment to study these illustrations of lung markings on trauma radiographs and the influence of fluids or lack of fluids within the thorax. Here we see a right lung pneumothorax where the air is pushing in on the right lung and shifting the heart and the left lung to the other side of the thorax. Let's see how the changes in volume of air within the thorax affect the chest. You'll see that as air pushes the heart and the other organs to the left, the right lung is losing all of the lung markings, and we can see very well the pneumothorax. As the lung collapses and air rushes in, it pushes all of the organs in the chest to the left side. By putting a chest tube in and releasing the air from the left lung, the pressure is released and the lungs return back to normal. We can see if the organs were shifted to the right lung, we would have had a left-sided pneumothorax. Next, we're going to take a look at how the lungs appear if the patient is in an upright position or in a decubitus position, and the lungs are filling with either blood or fluids. Here we can see an upright chest x-ray and notice how the costophrenic angles are filling with fluid. You always want to make sure to have the diaphragm and costophrenic angles shown on your chest x-rays. This illustration shows a lateral decubitus. Notice also on the lateral decubitus view that the downside costophrenic angle is filled with fluid because air rises and fluids fall. When evaluating a patient for a pneumothorax, we want to take an inspiration film and an expiration film to better identify the area of lung markings. It provides more contrast. This image shows a lack of lung markings and a clearly defined simple pneumothorax. Take a look at this image. Do you see a pneumothorax anywhere? How about now? Obviously, positioning and contrast are important in being able to visualize a pneumothorax. Here we have two views of a hemothorax. Which one is supine and which one is upright? Here we see images of a hemothorax, or fluid in the lungs. On the left, we can see that the patient is lying supine, and the fluid actually fills the entire cavity on the patient's right side. On the image to the right, we have the patient sitting upright, and we can see air fluid levels, where we see the difference in the fluid in the lung. This is caused by having the patient in an upright position. Remember, fluid falls and air rises when we have the patient in a decubitus or an upright position. This again shows us a hemopneumothorax. We can see the pneumothorax, and we can also see the blood in this as well. When we're looking at air fluid levels, we're looking for the fluid to fall and the air to rise. The patient should not have the images taken immediately, but should be either in an upright or a decubitus position for about 5 to 10 minutes prior to the exposure. This allows the fluids to fall and settle and the air to rise. Let's take a look now at a decubitus view. Notice here we have the patient lying on their side, and we can see the air fluid level down at the bottom of the image. Here we see a tension pneumothorax, and a tension pneumothorax is a life-threatening condition that must be treated immediately. With a tension pneumothorax, we have progressive loss of air into the pleural space, which causes a shift of the heart and mediastinal structures away from the side of the pneumothorax. The opposite lung is compressed and respiratory function is severely compromised. This image demonstrates a complete right-sided pneumothorax where the lung is compressed against the mediastinum. It is shifting the heart and trachea to the left. Here we see two images of a pneumothorax. On the one to the left, the right lung is collapsed, pushing everything to the left. On the image to the right, it's just the reverse. We have fractured ribs, and the left lung is collapsed, pushing everything to the right. This cross-sectional CT slice shows us the area of the mediastinum and the aortic arch, and also the tension pneumothorax. Notice how the tension pneumothorax is pushing all of the organs over to the left. Here we have a hemothorax, as we've been discussing. But did you know that we can also have a tension hemothorax? The tension hemopneumothorax, or the tension hemothorax, again, fills the chest cavity with fluid and blood, but with the blood pushing the organs to the opposite side from the chest wall. To alleviate a hemothorax or tension hemothorax, we need to ventilate the patient with 100% oxygen and a needle decompression if the tension pneumothorax is suspected. Chest tubes for pneumothorax or hemothorax are needed. We also need to have an occlusive dressing to put on the sucking chest wound. If intubated, we need to evaluate the tube position on the patient. Sometimes when we intubate the patient, we put the tube down too far and go below the carina, and we actually end up collapsing the lung. This image shows that a patient that had a hemopneumothorax had the fluids drained and their lungs ventilated, fully inflating the lung. Notice the chest tube that we have on the patient, the broken ribs, and the packing on the outside of the chest. Let's take a look at thoracic trauma and death. We have about 8,000 thoracic injuries annually, and the death rate is 85%. Here we can see the seatbelt has caused trauma to this patient in their mediastinum, and if we take a look at the cine, we can take a look at the aorta, which looks like a candy cane here, but the candy cane is broken, so we have a ruptured aorta. When we analyze a chest x-ray that has these markings, we have to look for the potential of a ruptured aorta, which would be a wide mediastinum, obliteration of the aortic knob, a right mainstem shift up and to the right. The nasogastric tube would be deviated to the right, and you'll notice the pleural cap. In evaluating a ruptured aorta, it is important to look at the bony framework, soft tissues, lung fields and hyla, diaphragm and pleural spaces, mediastinum and the heart, and the abdomen and the neck. Here we see an abnormal chest, which would demonstrate the aortic rupture. Notice the mediastinum and the other areas of interest that we talked about in the previous slide. In the previous image, we saw a widened mediastinum. Well, how do we know it's widened? We take a look at the mediastinal area. We're going to look for bony abnormalities, and we see rib fractures. We're going to see the mediastinum looks okay, so we don't have a ruptured aorta, but we do have pulmonary contusions, We do have subcutaneous air. That's air in the tissue. It's been forced into the tissue. We have a chest tube and we have a nasogastric tube in this image. At times we become very focused on just one particular area, and here we're looking at a chest contusion. But if we look a little bit farther, what we're going to see a scapular fracture on the patient's right scapula. As we discussed earlier, when putting an endotrach tube into the patient, we have to know where the carina is, or the bifurcation of the bronchus. And if we go down the right mainstem bronchus too far, we are actually going to end up collapsing the left lung. Again, we want to be able to see the different areas, so it's important to understand the wide mediastinum, the obliteration of the aortic knob, a shifting of the right mainstem bronchus, and a NG deviation to the right, nasogastric tube deviation to the right. In other words, it's being pushed over. So we know that we have a major vessel injury, like a aortic knob being fractured or ruptured. So what does that look like? Well, let's take a look here and see what we can find. First, we have rib fractures. Next, we take a look at the mediastinum and look at how wide that mediastinum is. And we notice that we've obliterated the aortic knob. We can't see it as well. It's sort of blended in. Also, notice how we have the trachea being pushed over to the side, over to the right. It's a tracheal deviation to the right. Also, notice that we have a chest tube in this patient because we have a pneumothorax. And now we're taking a look at the nasogastric tube, and we'll notice it too has been shifted to the right because of the pneumothorax. These images show what we would look at for a dissecting aorta with a trauma patient with chest or thorax trauma. With contrast, this image clearly demonstrates a dissecting aorta. Notice the tear. This is not a pneumothorax. This is actually a pneumomediastinum. And you can see the tip of the endotrach tube, and below it, the area where we have the pneumomediastinum. Notice the lack of lung markings, but also notice that we can see a lot of fluid in there. So what we have here is a hemothorax, but not only a hemothorax, but the organs are being pushed to the right, so we have a hemothorax that is a tension hemothorax. This is an upright chest x-ray, and you'll notice that we have an indistinct diaphragm here. And you'll notice also below it the stomach bubble has risen up. So do we actually have a ruptured diaphragm? This is what an elevated diaphragm looks like, and we can also see here a close-up of the diaphragm in the next image. Close-up look of the previous image. What do we see? Well, we can see some fractured ribs, multiple fractured ribs. We also see a fracture of the clavicle. And this area seems quite suspicious, so we might have an area where we have some separation on the sternoclavicular joint. We see the chest tube, and now we see that indistinct or elevated diaphragm, which can give us an idea that we have a ruptured diaphragm. Here we see a crushed right chest. Notice there is no air or very little air in the right lung area, but we do have a lot of air that has gone into the soft tissue or subcutaneous air. Notice the chest tube has been put in, and what happens after we put the chest tube in? Ventilate that area. Notice now that that area that was totally devoid of any air is full of air. We've reinflated that lung. After all we've evaluated at this point in time, take a look at this image of a patient who is sitting up for a mobile x-ray or a portable x-ray, and they have a hemo, pneumo, diaphragmatic, and stomachal rupture. In other words, we can see the bowels going up through the diaphragm, and this is a total mess for this patient. Our last of the big three exams is the pelvic exam. Take a close look at the normal anatomy of the pelvis and think about all of the areas that are being protected by the pelvis. Pelvic trauma is truly life-threatening and requires immediate response. A fractured pelvis that has arterial or venous damage cannot wait to go to CT but must be sent immediately to surgery. Pelvic fractures as a result of multiple traumas result in a 27% death rate for the patient, and more than 50% of patients with a fractured pelvis are results of a pedestrian auto accident. Take a moment to visualize what type of structures would be compromised by the jagged edges severing the soft tissue and vasculature. You have to be able to understand what is contained in this area that we do not see because we're looking at bone. Notice in the area we're looking at the iliac arteries, the aorta, and a lot of arterial vasculature. Not only are we looking at the arteries and the venous structure, we're also looking at the ureters, the bony area, and soft tissue area and other organs. You can see why the pelvic fracture is one of the most horrific fractures and one of the ones that needs to be taken care of immediately. You don't need to be playing with trying to get a lateral C-spine on a stabilized patient when they have a pelvic fracture and they might bleed out. Here we have a pelvic fracture with a dislocated hip, and this patient will probably be going to surgery. So how do we move the patient without destroying some of the tissues that surround these areas that are fractured? And what will the patient have done to them in surgery? Well, let's take a look and see what we can find. Demonstrate post-surgical fixtures that are put into the pelvis to stabilize it after the fracture. As you can plainly see on these three simple exams that are portables that are done in an ER trauma room, that the key to any X-ray interpretation is knowledge of the anatomy, what is normal, and a systematic approach of evaluating what you see on the images. The most common plane images used for adult multiple trauma patients are the cervical spine, chest, and pelvis. This is Mark Struthers. Please subscribe to the channel and look for more of your information on medical imaging.